So as I already said in my introduction, I'm the project manager of the Manchester Self-Harm Project. Our core remit on the Manchester Self-Harm Project is to collect detailed information on people who present for self-harm to the emergency department in Manchester, and we collect from 3 hospital emergency departments in Manchester, and we collect data from the Mental Health Trust. So I'm quite familiar with clinical coding, particularly emergency department coding of self-harm and the issues around it. So that's what I'm going to talk about today. That's what I'm going to focus on. I will also talk a little bit about outcome measurement. This is not my area of expertise, but I will point you in the direction of some resources that hopefully would be helpful in that respect. Okay, so first of all, I'm going to talk about routinely collected data. So this is, as I'm sure most of you are aware, is the kind of clinical and administrative information that's collected as part of patient care. This kind of information is often used for, well, actually, the main reason it's collected is to do with the funding, the way the NHS is funded. So it has to be submitted to various data warehouses to for service funding and provisioning. It's also used for secondary purposes such as research. The one of the good things about routinely collected data is that it is very accessible to people who work within trusts and different organisations. You will locally have business intelligence teams, things like that, who you can approach for reports based on different variables and fields, the way the fields are coded. And it actually has quite good coverage in terms of any patient that presents should have some data recorded about them on the local systems. There are some limitations to this kind of data that I'm going to go into a bit more detail about, but routine data can be used to look at some more broader issues, sort of changes over time and things like that. And it can be used in other ways with a lot of sort of caveats and things that you need to keep in mind. Okay, so first of all, a few years ago, we did a comparison of our sort of gold standard self-harm data collection that we at Manchester do. We also work with similar, very robust self-harm data collection sites at Oxford and Derby as part of the multi-centre study of self-harm, and this used all 3 sites. We compared a few years of our gold standard data with data from the emergency department via hospital episode statistics. And what we did a direct comparison on area based, so the hospitals that we collect data at are the hospitals that we got the information from HES from as well. And we found that the HES data, the emergency department HES data, underestimated the number of self-harm presentations by up to 60%. It wasn't that high. There were slight differences between centres, but overall it was about 60%. So that's quite a lot of cases that are basically missing if you use the routine data. So I'm going to go into a bit more detail about what we do to get our sort of really high standard robust data from the emergency department records, and in the course of that I'll explain sort of why, some of the reasons why the cases are missed in routine data. So one of the things that we do is we take a lot of time. We look into very detailed patient records, we look into individual records, we have a lot of attention to detail, and most of all on our project we have a really excellent team of expert data collectors who are experienced in looking at patient records and identifying episodes of self-harm. Okay, so this is an example from one of our sites. We actually have 3 hospitals in Manchester that we collect data from, and this is one of them, Manchester Royal Infirmary, or MRI. And what we do is, first of all, from the initial all emergency department presentations, we use various sort of keywords and search terms to whittle down to a group of potential self-harm cases. Those potential self-harm cases, our data collectors then look at each individual case and decide which ones are and which ones aren't self-harm based on the information there. As a kind of rule of thumb, one of the things we use to determine whether it's self-harm is whether the clinician has considered it self-harm in that instance. If there's a bit of lack of clarity on a particular case, then the data collectors can bring that back to the team and we discuss it as a group and can make a decision on whether to include it in the our self-harm database or not. Okay, so then we have the final decision on whether a case is self-harm or not, and if it is, then we collect the information, and you can see some of the figures there, sort of monthly figures from 12,000 ED presentations. We end up with initially the potential self-harm group of about 400-ish, and we whittle those down to the confirmed presentations, which are about 140, 150 a month. Now, obviously, not everybody's going to be able to do this kind of work, so we do have to look at other ways of collecting data for other purposes. But just to go into a bit more detail about our potential self-harm group, this is an example from one of our hospitals of the kind of terms that we use to identify things that might be self-harm. So at the top, we've got area of the body. So is there particularly this is to do with the injury location? So is it forearm, wrist, neck, that kind of thing? That might be an indication that the injury is actually self-harm. So we would look those up. The main kind of error, if you like, or miscoding of self-harm is that the presenting complaint will be coded instead of the actual self-harm. So, excuse me. So it could be things like just a laceration or injury or stomach issues, perhaps for an overdose, or it could be something more sort of psychological or psychiatric, so depression, psychiatric problems, and that kind of thing. So we have a really broad sort of group of terms that we use, and it's actually a group of terms that we've developed over a number of years. The project's been running for nearly 25 years now. So with all that experience and with various audits that have been done, and our, as I say, our data collectors who are very experienced noticing things, new codes that are being used for self-harm, we've been able to develop this quite big list of potential cases that may potentially be self-harm, which are then looked into further. The last group we have there is just where the injury or event took place. So we include if people have been, their injury or poisoning or whatever it is occurred at home, we would look into those as well. Okay, and here are just some examples of the kind of codes that we commonly find. Some might be quite obvious, so deliberate self-harm, suicidal, self-poisoning, but also things like burning, fall, bizarre behaviour. There was one example from a few years ago now where our data collectors noticed that there was a drop in self-harm at one of our sites compared to the other two, and there didn't seem to be a reason for it. So going back through the records, doing a kind of mini audit, if you like, of that site, what they identified was that there was a particular person coding self-harm as head injury. We're still not sure to this day why they were doing that, but it's part of the reason why we also have parts of the bodies, in our list of sort of flags to look up potential self-harm. So we were able to then add that to our list, and going forward, we're able to capture those episodes. Okay, so as I said, although there are these issues with coding and why coding may be missed, routine data is still useful. So as long as you're working, acknowledging the limitations that you're working within, it can still be a good source of sort of baseline data for you. And just as an example, during the early years of COVID, early on in COVID, we wanted to look at more up-to-date data because our very detailed data collection takes some time, so there is a lag in when that's available. We wanted more up-to-date data, so we asked, this just says MRI, but actually we asked all our hospitals to provide ECDS data, that's emergency care data set data from the emergency department, which we get now on a monthly basis. And you can see the chart at the bottom, which is just the first sort of 6 months of 2020. Although we know that these data will be probably 50%, maybe even more missing, so underestimated, you can still see that there were changes over time. You can see that there was thick line there on the chart is where the first full lockdown, and you can see that there was a drop in presentations to the emergency department. And we obviously have more data now, so if this chart was to go on, you will actually see that it's like it goes back up towards approaching pre-pandemic levels eventually. But it's that kind of thing that you can see, as long as you're fairly confident that the amount of incorrect coding or missing coding of self-harm is roughly going to be the same over time. You can still detect some more sort of significant changes. Okay, and following on from that, it's possible to do sort of shorter term audits. So, perhaps using some of the kind of fields that I've already talked about that we use. For example, you could audit, say, 3 months of data from your local trust or primary care or wherever it is that you want to establish how many self-harm cases are being seen or how many patients are coming in, and use those broader search terms and get a helpful administrator or junior doctor or somebody to look in detail at those cases and identify which one are self-harm. And that will give you some idea of how many, or the percentage of cases that are actually being underestimated through your routine, through the reports that you can get, for example, from business intelligence. And also the other thing you can do once you have that information is that, with a lot of caution and a lot of caveats, you can create a very rough estimate of what your numbers would be based on the routinely collected data. So looking again, this is just the top line from that the HES table from the 2016 paper that I already showed you. If you look at the actual numbers and the underestimate, so we've got case ascertainment. There was about 40%, 41% of ascertainment of the actual self-harm cases for that period of time. The number that we had was around 207. So if you do a little bit of maths on that, you get a figure of around 497, which is very close to the 500 that we actually got. So although it is an estimate, and obviously that has to be taken into consideration, if you do have, even a sample, a few months worth of accurate data, you can make those kinds of, estimates. Okay, so the good things about routinely collected data, there is some evidence that the coding of self-harm is improving over time. Some of that could be to do with just general awareness of self-harm, general awareness of self-harm sort of within the population, specific training, which could be, part of your plans even, for this work, could be staff training around awareness of self-harm and how to code that. Coding a mental health trust does tend to be a bit more accurate. From our perspective, we use data from psychiatric liaison teams who were seen in the emergency department. However, we are aware that only about 50% or 50 to 60% of people that attend the emergency department of self-harm are seen by psychiatric liaison. So again, it's just something to keep in mind. And there are also increasingly software solutions that can help with this kind of issue. Things like adding pop-ups or extra fields that have to be completed when a clinician, opens a patient's notes to add information. Again, during the early part of the pandemic, as part of the work we did around COVID, we asked our local trust to add a pop-up field to the psychiatric liaison team when they code for self-harm. And we added a field that was asking whether that episode of self-harm was related to COVID or not, and if it was, then how it was related. So it's just a very small field that they had to fill in before they could sort of close out of that page. So there are those kinds of solutions as well that can help improve the coding of self-harm. Okay, so now we're coming on to outcome measures. As I mentioned, I'm not an expert in this, but there are people who are expert in it, and they very helpfully devised a data dictionary. This is some of the Enkish people who put this together, and it is on our website. So I've got the link to the website there. You can also access it just through the Manchester Self-Harm Project main website. It's on the ribbon at the top, the community-based care for self-harm. I think I'll probably get these slides emailed around to everybody anyway, so you can use this link here. And I've just got a screenshot. So you just scroll down the page and it's under data dictionary, and there's a PDF link, so you can open that and save it. So the next bit of information really is taken mainly from there. And also they have more details. I'm just going to do a really brief overview of suggestions, but they have more resources and links that are linked to in that document. So first of all, there's a few things to consider when thinking about how to measure the impact or outcome of your plans and interventions. First, is there robust baseline data that you can measure change against? Second is what kind of data could be used to measure or evaluate the impact of your intervention or plan. And third is whether the data is of sufficient quality to robustly measure change. For example, how were the data collected and by who? How complete the data is? Was the data collection standard or mandatory, or what I would call routine? Were there any inclusion or exclusion criteria? Okay, so when you go to the document on the website, this is what it looks like. It's a list of well, it's under headings. This one is the main self-harm data, so that's kind of what I've already been talking about. So you can create rates of self-harm if you have, say, hospital information or GP information, and you can compare that to your local population figures from ONS to create rates of self-harm. There are also process measures. So if you're planning an intervention or group or something, this one is specifically about peer support groups. Some of the suggestions include counting the number of patients recruited for a peer support group on a weekly basis, looking at the number who engage with the support group, and getting feedback from the people attending the support group, as well as the people running the support group. Okay, if your plans include things like developing a website or resource, electronic resources, an app, something like that, you can look at the number of clicks through from the app or website to potentially other partner websites, the number and proportion of people signposted to other services following using your resource, the number of downloads of an app, if that's what you're creating, and media engagement around that resource. These aren't exhaustive. There's a lot more information in the document. These are just a few examples that I picked out just to illustrate the kind of thing that we're talking about. So for therapy or intervention, more direct interventions, the number and proportion of people who reattend for self-harm following the intervention, which of course you'd need a good baseline for that to start off with. The number and proportion of patients offered or referred for the intervention, and the number who then take it up and actually attend, and possibly how many sessions they attend. Broader patient feedback might be important, as well as staff feedback on the intervention, particularly if it's a new intervention that you're offering. Okay, so we've got some information around management, care management and safety plans as well. So, for example, the number of comprehensive safety plans that have been done based on the assessment of different people and different risks. The number and proportion of staff who've received training for risk assessment, including how to assess, formulate and manage risk, as well as training on being comfortable talking about suicidal thoughts and self-harm. The number and proportion of safety plans that are collaboratively developed where appropriate with families and carers. And a little bit on psychosocial assessment. The number of patients receiving a psychosocial assessment could be collected in line with nice quality measures. Then feedback from those receiving assessments, as well as staff feedback. Okay, and we find that quite a lot of people's or areas plans do involve staff awareness and training, which is also something that can help with the coding of self-harm. And some of the suggestions on outcome measures for these are the number of staff attending the training sessions, the type of person attending. So is it frontline staff? Is it nurses? Is it more senior clinicians? And once the people have attended the sessions, there can be feedback via questionnaires or evaluation forms on how they found the training and how useful they think it is and how useful it's going to be sort of in their work going forward. The number and proportion of patients, I think this is an interesting one actually, the number and proportion of patients referred or signposted to mental health or other support services, this says by primary care professionals, but it could be anyone, once the training has been done. So again, you know, looking more broadly at how many people were being referred before the training was done and how many people were being referred after, to see if there's a change and whether that change might be due to the training itself. So I got through that a lot quicker than I was expecting. Thank you for listening. I've got my email address there on that final slide, as well as the general self-harm support email. If you have any questions, particularly around the clinical coding aspect, but anything at all as well, please feel free to contact me, and I will do my best to try and answer your questions. Thank you.